Good afternoon. I'd like to call the Population Health Subcommittee to order. It's Tuesday, February the 14th, 2023. We would like to recognize our doctor for the day, who is James McKenzie, and he is here in Nashville. I know, were you out here anywhere? Okay. Okay, so we're ready for the clerk to call the roll, please.
Clemens. Here. Farmer. Haynes. Here. Hammer.
Warden.
Oh, Michelle.
You have a point.
I must say I'm a little bit speechless at the moment. Even the sweetness gets to him every now and then. So I am glad to see this. This is record breaking right here. Oh, wow. Okay, well, I tell you, you never know what's going on. So, okay, we've got a regular calendar today. And so I'd like to go ahead and get started on it. It's House Bill 0883 by Chair Lady Haynes.
Second.
Thank you, Madam Chair and Committee. Good afternoon, members. I'm here to present today House Bill 883, which has been called the Life of the Mother Post-Dobbs Cleanup Bill. This bill has an amendment, Drafting Code 3797, that rewrites the bill. I would appreciate a motion and a second.
Okay, so we have got a motion and a second to discuss the amendment. Okay, so we'll let Chair Lady explain, and then we'll go out of session a little bit, and we'll have testimony.
Thank you. Thank you, Lady Chair. First and foremost, the AG has seen the language and signed off on it. I'm sponsoring this bill because I believe we need to ensure that we protect the life of the mother in a medical emergency. The most common cause of life of the mother medical procedures is the removal of an ectopic or tubal pregnancy, which is estimated to be 1 in every 50 pregnancies. However, you cannot predetermine every scenario that a physician will have to use their judgment in an emergency or in a non-survivable fetal anomaly. Therefore, good faith medical judgment will have to be used. In the trigger, good faith medical judgment was used as the standard, and to be consistent, we use the same standard. This bill not only clarifies saving the life of the mother, but also the life inside the womb. Here is more detailed information about the bill. It clarifies that commonly performed medically necessary procedures, such as ectopic pregnancy removals, are not criminal abortions. It defines criminal abortion in the bill. It provides clarity and sets parameters for physicians on the medical actions they need to take should they judge a termination of a pregnancy be medically necessary to save the life of the mother. It authorizes the Tennessee Board of Medical Examiners to hold a hearing to determine the medical necessity of the abortion before a criminal trial is held. This bill allows for termination of a pregnancy when a non-survivable fetal anomaly is diagnosed. A non-survivable fetal anomaly is a fetal condition diagnosed before birth that in the physician's good faith medical judgment is incompatible with life outside the womb and for which medical intervention would be futile. Good faith medical judgment, and as a reminder, we are consistent with the language used in the original trigger law. It also provides immunity for pharmacists for dispensing drugs that have other recognized non-abortion indications. This bill removes confusing and conflicting laws and language that were superseded by the trigger law. In closing, the current trigger bill is confusing and contradictory, and it makes a physician guilty and they must prove their innocence. This bill provides better clarity and returns to normal judicial system practice, innocent until proven guilty. It protects the life of the mother and the life of the baby. Finally, who would want to tell their spouse, child, or loved one that their life is not important in a medical emergency as you watch them die when they could have been saved? This bill clarifies what I believe the original intent of the trigger bill was, which is to ban elective abortion in the state of Tennessee. Thank you.
Thank you, Chair Lady Haynes. At this time, we're going to go out of session, and we've got those who want to do testimony, and you will be given 3 minutes to do your testimony, and we're going to start with Dr. Kim Fortner. And please come to the mics, make sure they're turned on, and tell us who you represent.
Good afternoon. Can you hear me okay? Yes? I'm going to do plus. Okay. Good afternoon. My name is Kim Fortner, and I'm here representing obstetricians and gynecologists in the state of Tennessee, but more specifically, I work at the University of Tennessee Medical Center. Is it okay to start my testimony? Okay, great. Thank you. So, good afternoon, members of the Population Health Subcommittee. As I said, my name is Kim Fortner. I'm here today to speak in support of House Bill number 883. I'm a native Tennessean, a member of the TMA. I grew up in Oak Ridge, Tennessee, and I graduated from the University of Tennessee. I completed my residency at Johns Hopkins in obstetrics and gynecology and returned to Tennessee to spend my career taking care of mothers and their babies. After 3 years in practice, I realized I wanted to do more, specifically more for complicated pregnancies. So I completed a 3-year fellowship in maternal fetal medicine at Duke University. After fellowship, I spent 4 years as faculty at Vanderbilt Medical Center. And in 2015, I returned to the University of Tennessee Medical Center and am now the Vice President of Women and Infants Center of Excellence and the Division Director for Maternal Fetal Medicine. Truly, I have spent my career helping women become mothers and parents become families. Most of my day is spent in the room congratulating women on normally developing pregnancies or managing mothers' high-risk conditions like hypertension and diabetes. But not all pregnancies are the same. There are also rooms full of tears where we're discussing an abnormally located pregnancy, as in an ectopic, or an evolving miscarriage where, despite the presence of a heartbeat, the gestational sac has slipped from the top of the uterus. It never gets easier to tell a mother she has a pregnancy that's either not located or not staying in her womb. What makes it easier is knowing clear medical or surgical management are indicated to keep her from life-threatening bleeding. These cases, which should not be questionable, are now questioned by the care team under the current law. The harder, or grayer, if you will, cases are in the rooms where ultrasound has identified an abnormality in her baby that is not compatible with life outside the womb. Or, less frequently, and arguably more concerning, the mother has complications that would make pregnancy life-threatening for her, such as a heart attack, an acute diagnosis of cancer, heart failure, or any organ failure. This bill clarifies exceptions to these exceptionally difficult moments when pregnant women's life are at stake. It allows the medical professionals the ability to practice safe medicine and to save the mother's life or even her future ability to carry pregnancies. House Bill 883 remedies the current hindrance and, frankly, the fear faced by providers, the time burden and the risk to mothers' lives while we are forced to pause in her care, to call another colleague, to find another anesthesiologist, to find another provider, or our legal team, or our risk management team. I would rather use that time to be confident in her diagnosis, to be confident in her understanding her options, and when it's safe and available to do so. When time is of the essence, I don't want to hold my breath hoping for colleagues who will take a risk with me and help save a mother. Most of all, thank you for your time today in consideration of this bill.
Thank you. Okay, next we will have we'll have questions afterwards. We'll hear from all the testimonies, and we'll come back and we'll have questions. Okay. Next we have Will Brewer.
Can you hear me? Okay. Thank you, Madam Chair and committee. I'm Will Brewer. I'm legal counsel and lobbyist for Tennessee Right to Life. I come here to speak in opposition to this bill, but first I would like to thank Representative Haynes for clarifying in the first part of the bill that this is an unborn child. We are dealing with not a fetus, not a pregnancy, not a future birth, but we are dealing with a child. And in these instances, there are two patients. So I would like to thank Representative Haynes for the clarity in that, and I would like to thank her for including a born alive provision in this bill that helps this baby survive if they are outside of the womb. So thank you for that. Those are the good portions of this bill. I want to clarify one thing. The original trigger law or Human Life Protection Act did not have a subjective standard, which is what this bill has. It had an affirmative defense that within it contained a subjective standard. If it only contained a subjective standard, you all wouldn't be here today because that's what this is trying to put into that bill. The majority of this committee voted for the Human Life Protection Act in 2019. The majority of the House voted for this Human Life Protection Act in 2019 because it was a good bill. It is a good law. It's saving over 900 babies a month. And I agree with the principle that we need to care for the mother and the baby, especially in these difficult circumstances. And I believe that there is a way to clarify the Human Life Protection Act so that we do that effectively, so that these doctors that sit behind me today are more comfortable with the language. However, this bill is not it. First of all, by asserting a subjective standard, which is the physician's good faith medical judgment, you are getting inside the head of that individual physician at the time that the termination occurred. That is virtually unprosecutable in a court of law. If a doctor were to abuse this statute, it would be virtually impossible to successfully prosecute that doctor. Once one doctor is let off the hook in a criminal trial, a doctor that abused the nature of this law, it would be open season for other doctors who wanted to perform bad faith terminations to do so, knowing that this law is unprosecutable. Second of all, there is a clause in this law that said it allows doctors to treat and prevent a medical emergency. The prevent language has me concerned because that would mean that the emergency hasn't even occurred yet. And it doesn't specify what the certainty would be to be able to prevent. So there needs to be a certainty for preventing a medical emergency. There needs to be a certainty defined in this bill for what a fatal fetal anomaly is and how certain the doctor is that it is occurring. There needs to be more certainty on what a medically futile pregnancy is and whether it is occurring. This law is vague on all of those, and I believe that that opens up room for abuse of this statute. Furthermore, the law repeals what's known as the heartbeat law. That heartbeat law is a safety net. If this law is ever enjoined by a court or repealed by a future General Assembly, the heartbeat law is in place as a safety net. If you repeal that from the books, then we no longer have a safety net to fall back on. Any attorney worth his salt would put a supersession clause in this bill which says that this law supersedes the heartbeat law. The heartbeat law is suspended while this law is in effect, and if this law were to ever be enjoined or struck down, the heartbeat law would be reinforced. That's what happened to the abortion ban from 1973. It remained on the books until Roe was overturned. Finally, the last part that I have an issue with is that by defining an intrauterine pregnancy, it allows RU 486 to be prescribed between fertilization and implantation. So effectively, RU 486 can be prescribed in the first 10 days of pregnancy without any consequence. So for those reasons, I would ask the subcommittee to go back to the drawing board. Let's find a way to include an objective standard, which is a good faith medical judgment on behalf of the medical community. It's the same standard used in malpractice statutes, and I believe it's what should apply
Time
here.
is up.
And thank you for your consideration.
Okay, next we have Dr. Yarnell Beatty.
Madam Chairman, members of the committee, thank you very much. My name is Yarnell Beatty. I'm not a physician. I'm a lawyer. I'm with the Tennessee Medical Association General Counsel. An important aspect of this bill is that it corrects a legal issue regarding the affirmative defense. Right now, a physician who saves the life of a mother who has pregnancy complications could only defend himself or herself after being charged with a crime. What this bill does is it makes that due diligence take place before a charge to make sure that all the elements of the crime are met before charging. The reason why that's important is because once a physician is charged with a crime, that physician is subject to immediate penalties such as loss of hospital privileges, being kicked out of health insurance networks, losing jobs, having their face splayed across the hometown newspaper in rural communities. So in effect, their reputation is dead before they've even had a chance to defend themselves. What this bill does is it makes the affirmative defense, it takes the affirmative defense out so that all that due diligence must be done before the physician's charged. And in that case, that will keep those negative consequences from happening before the physician's able to defend himself or herself. Thank you.
Thank you. Okay, we are still out of session, so we want to take any questions from our committee.
Thank you. I'd like to kind of have Will Brewer come back up. All right. Thank you. I guess, could you explain a little bit better the issue on the objective versus a subjective standard, particularly as it relates currently to the trigger law? We have the affirmative defense, and there's a subjective standard in that physician's good faith medical judgment. This would keep that, this amendment would keep that, but we're taking away the affirmative defense and explain how the objective standard would work.
Yeah, thank you, Chairman Terry. It'll take me at least 3 minutes alone just to explain that concept. So there are essentially three standards that could be applied to this type of law. First is what is applied now. It's an affirmative defense that within the affirmative defense contains a subjective standard. So, and I explain it to folks this way. If you are in your house at midnight and somebody breaks into your house and you shoot them dead, you have essentially killed somebody, but you have a defense that you did so in self-defense. And so the police would come to your house, they would ask you questions, they would investigate, but they most likely would not charge you with a crime, seeing the evidence there. The same is true in this. This is the taking of a human life, and so it should have the same level of standard as other laws that take a human life. However, it is not a foregone conclusion that the doctor will be charged with a crime before he or she is available to assert an affirmative defense. And that is why the subjective standard is applied to the affirmative defense. It gives that doctor more leniency to exert their reasoning for the termination within the aspect of the affirmative defense. We have had an affirmative defense in our post-viability ban since 2017. No doctor has ever been charged with a crime under that. There are multiple states now with similar trigger laws on the books post-Dobbs. No doctor has been charged or prosecuted under those trigger laws. So because you have the affirmative defense, which in layman's terms has more teeth to it, you assert a subjective standard, which is what was that physician's good faith medical judgment in the moment of the termination, to allow for a balance of the two concepts. If you have an objective standard, so let's do away with the affirmative defense. We're now in objective versus subjective territory. An objective standard is what is reasonable medical judgment, and that is determined by essentially what a consensus of the medical profession would do in that moment. It is the same standard that's applied in medical malpractice statutes in this state, and it does not preclude prosecution, neither does a subjective standard, but in an objective standard, you would typically have the state would bring on expert witnesses onto the stand, and so you would trust that those expert witnesses would corroborate what the physician that performed the termination did and the reasons for doing so. If a consensus of the medical profession wouldn't agree with the termination, well, then you're not acting in reasonable medical judgment. With a subjective standard, which is what's being applied in the bill before us today, the subjective standard is what is the physician's good faith medical judgment at the moment of termination. And so basically any physician can come up with a reason for doing a termination, whether it's good faith or bad faith. And I'm not saying that the majority of these terminations are done in bad faith. I am saying with the wording of this bill, bad faith can be asserted by a physician and used to their advantage with a subjective standard, because no prosecutor would be able to successfully prosecute a subjective standard termination of pregnancy, because it's only in what was in that physician's mind at the time, and that's difficult to overrule.
Thank you. Follow-up question, and this goes to, and you and I have had several conversations on this, and it goes to the definition that's currently in the Human Life Protection Act. And as it's currently defined, I think it's too broad. It does not have, when we are talking about abortion in layman's terms, but in medical terms, we're really talking about elective induced abortions, and ectopic pregnancy was left out, and it's obviously in this. The other issue has to do with medical emergencies and particularly life of the mother in those exact instances. In this bill, it's obviously the subjective standard on a medical emergency. But everything else, I think, may have some time involved in the decisions that you have to make. Where would Tennessee Right to Life stand on changing the definition, clarifying the definition, and particularly as it relates to an emergency and the standard relative to that emergency?
Yeah, there's been much made in the media about our stance of this law, and I think the majority of folks that would read such articles would come away seeing that we don't want any change to this law, and ideally that would be our most preferential option. But I do agree with Chairman Terry that there could be room to further elaborate and define that an ectopic pregnancy or a miscarriage removal and treatment could be further clarified so that they are that nobody is mistaken that those things are not contained in the prohibition, that it only applies to elective abortions. And so I've worked with you, Chairman Terry, and I've spoken with the majority of members on this committee to say that we are open to such clarifications. And as much as I would love to stick with the affirmative defense because I think that it works, I am open to applying an objective standard to this law if that would clarify some things. And Chairman Terry, you and I have worked on some language, and I've offered to produce that language for other members of the committee as a possible amendment to this bill. But as much as I would like to hold firm to the Human Life Protection Act as it is written, because I think it works, and I don't think in the history of abortion statutes in this state, in the last several years, that things like ectopic pregnancy are typically included in the definition of what an elective abortion is. We are open and supportive of clarifying that definition so it's very clear that those types of issues are not included.
Chairman.
Thank you. And just one more question. Currently, based on the current language, and you're saying moving to a total subjective, Tennessee Right to Life would not consider this a pro-life bill. Could, based on if definitions potentially were shored up, we had, and I'm of the opinion that, in a life and death situation, I've been pretty open with folks that I'm okay with the subjective on that. The others, I'm more of an objective, but could that be shored up to improve this piece of legislation?
Yeah, and you and I have discussed this, and I think we agree to disagree on the subjective standard applied to any part of this law, especially an emergency situation. I also think it's confusing to have multiple different standards in the same law. I think it needs to be consistent throughout. But the way that this bill is written, as well-intentioned as it might have been, I do not consider it a pro-life law because of a few factors. First of all, the subjective standard doesn't allow bad faith performers to be successfully prosecuted. That allows a lot of bad faith terminations. Second of all, and you hear it every day, there are instances of issues with pregnancy that could be considered an emergency, or at least could be possibly considered an anomaly or medically futile, that work themselves out. And so I'm not talking about an 11th hour, patient comes into the ER bleeding out, and what do we do? I'm talking about there is a condition here that some doctors would say constitutes an emergency worthy of a termination, and other doctors would say, let's pause and wait this out and see how it goes. I wouldn't want the former to terminate when the latter says there's room to see how it goes before this is urgent enough. So I think that there is room to further clarify the definitions in Representative Haynes' bill to include more certainty in things like a medically futile pregnancy or a medical anomaly. But certainly it is not a pro-life law if it is including treatment and prevention of a medical emergency, and it's not a pro-life law if it is allowing for RU 486 in the first 10 days of pregnancy, and it's immunizing pharmacists from dispensing RU 486. So no, I would not consider this a pro-life law, and in discussions with our PAC, they have informed me that they would score this negatively for those members that wish to vote for it. I would much prefer that this language came out yesterday. It involves multiple legal and medical intricacies, as is evident by the room of lawyers and doctors in this room. I would like more than 24 hours to go through it and to try and fix it so that it is a pro-life law and it's doing what it says that it wants to do, and it's not allowing for such bad faith actions to occur.
Okay, Chairman. Okay. Chairman Farmer, like to speak?
Thank you, Madam Chair. Mr. Brewer, we spoke yesterday on my way into town. Now, you would have to agree that this bill does not provide for any elective abortions, correct?
Correct.
Okay. You'd have to agree that this bill also provides for not only the life of the baby or fetus, it also provides for ensuring care for the life of the mother. Is that correct?
So that part is correct, and I certainly agree with that principle of providing protection for the life of the baby and the mother. Pro-life is for everyone. Your previous question, though, I would say that it allows for what I would call quasi-elective abortions, which are abortions that aren't necessary to be done in the moment, but are still performed in an effort to prevent future medical emergency. I think the lack of certainty with what that medical emergency is allows for quasi-elective abortions to be performed, and I think that that's completely unnecessary.
Madam Chair. And I appreciate that, but this bill has no language with regards to quasi-elective abortions. This bill speaks to abortions and does not speak to an elective abortion at all.
I'm talking about effect rather than language. The effect of the language would result in a quasi-elective abortion.
Fair enough. Well, I'm here to talk about the black and white on the paper I'm looking at right here. Does not provide for elective abortions. So, just to make that clear, right? So the intent behind this legislation, in my opinion, is to do two things: save the life of the mother and save the life of that baby, if it ever could become a baby. It's a fertilized egg that at some point in time may end up outside of the area. I'm not a physician. I apologize if I butcher this, but to me it seems like if there's a situation that there's maybe a fertilized egg that is just never going to survive. It's outside of the womb. It's a tubal ectopic pregnancy, something like that. We don't want a doctor to look at a situation maybe early on and maybe just last minute, right? You made a comment, maybe a female's laying on the table bleeding out at that point in time. We hope that never happens, but it does. Even early on, these things can be addressed early on. Doctors know we have ultrasounds, we have machines and and things that can see inside the body, and doctors use those as well as their experience to make those decisions early on to see that these don't become, life-threatening end of the hour decisions. So, it's the policy and the intent behind this legislation is to take all that into consideration and also to allow our doctors the opportunity to make those decisions when they need to make those decisions and not say, hey, you know what, it's time out. I'm going to have to step out here and look at the law book, call my lawyer before I come back in here and take care of this mother with this child when I'm trying to save them both. That's what we're here for. And I know we're not going to agree as of right now on some language in this bill, but this is what this bill does. Then we get into the weeds about this subjective and objective. And yeah, in the trigger bill, it talks about, the subjective language, and you say it's because of the affirmative defense. Well, thinking through this, I think it's more along the lines because it's a crime. Someone will eventually be objectively, if you're charged with a crime, then there's going to be an objective opinion made by a jury at some point in time or a judge. And you say, well, hey, we got this in a medical malpractice. Well, that's different because that's civil in nature. That's not a crime. We're talking about C felonies here. We're talking about jail time. Med mal, as far as I know, I don't think you can go to jail for a medical malpractice claim. Right? Sure, it may be objective there, but you're charged with a crime where you can lose your liberty and go to jail. Sure, it may start out subjectively, but it's sure as heck going to be viewed by those who are going to make the determination whether or not you committed that crime objectively. So I would say there is an objective standard that will come along at some point in time. But a doctor making a good faith medical judgment based off his or her subjective belief of what's going on, trying to save the life of the mother, trying to save that child they can, looking at all the technology around that operating room or wherever it may be. Yeah, you may say it's subjective, but there's other objective things, and there's been taken into consideration when a doctor's making that subjective opinion at that point in time, trying to save the life of the mother, trying to save that baby if they can. And yeah, they may be objectively judged at the end of the day if they are charged with that crime based off whatever came off those charts and those machines and what that doctor's done. And that doctor very well may be judged by a set of his peers in front of the medical board at some point in time. So I don't want us to get too far in the weeds over the subjective and objective standard because I think that both will come into play with regards to this legislation at some point in time. If God forbid someone does come in here and try to usurp our good policy, our good-willed policy here, trying to save babies, trying to make babies come to life, and trying to save the mother as well. But I think we just get in the weeds when we're talking about subjective and objective, talking about medical malpractice, which is civil, talking about a crime, a C felony, and a misdemeanor, which is criminal. So I kind of think that's where we're in the weeds there. But I think we're all on the same page when it comes to being pro-life. I was proud to have voted for the trigger bill, and I'm going to be proud to vote for this bill when it comes to the opportunity to vote for it here when this testimony's over. So I don't want anyone to think that we're not all here for the same purpose. And thank you, Madam Chair.
May I respond, please? The law as it's written is considered to be the strongest pro-life law in the country. A doctor has not been prosecuted. To my knowledge, a woman has not unnecessarily passed away due to the language in this bill. I believe that doctors are used to the standard used in malpractice statutes. Yes, malpractice and crimes are two different areas of the law, and you and I as attorneys both recognize that. However, this is the taking of a human life. Whether that taking of a human life is justified, it is the taking of a human life. I completely agree with you that things such as ectopic pregnancy, things that exist outside of the uterus, should be accepted, should be not prohibited under this law. But the taking of a human life, whether it's justified or not, should have the strongest standard possible. It's that way in the rest of the criminal statutes that deal with the taking of a human life, and it should be that way here. This is a baby and a mother. They should both be protected, but the doctor should be subject to a stringent law that prevents bad faith terminations from happening. And I believe that this is vitally important to have more than 24 hours notice to discuss this and to get into the weeds is vitally important when you're dealing with a law that takes a human life, whether it's justified or not. So I would like to get into the weeds if this committee would allow it.
Thank you. Clemens? Representative Clemens.
Yeah, thank you, Madam Chairman. I'm just curious, Mr. Brewer, are you familiar with other laws in other states that have an affirmative defense in them?
I am, yes.
And have any of those laws been blocked or partially blocked by courts because the law conflicts with federal law, such as or including EMTALA?
EMTALA. To my knowledge, no.
You're not
I'm
fam-
sure you have other information, but to my knowledge, no.
You're not familiar with the Idaho law and the ruling of the court in Idaho?
I am familiar with that now that you say so. I do know that Ohio, Kentucky, and Texas all have laws that have not been struck down.
Okay. That's the only questions I have, Madam Chair, but I would just like to add, I kind of take offense. It's beneath the dignity of this committee, and it's an offense to my colleagues in here to have a witness come before this committee and assert political campaign threats during testimony. That's completely disrespectful of this committee.
On the bill.
Thank you, Madam Chair.
Okay, Chairman Kumar.
Thank you, Madam Chair. Thank you for coming. Certainly, you represent a powerful organization, and you're well respected, and most of us have been on the same side of this issue, and we still are. There are certain differences in interpretation, and you're right, that is getting into the weeds, and one can get lost on it. But I think major things that stand out are, number one, you made a statement that you are fine with the current trigger law as it is, and nothing more needs to be done. Did you believe that?
I said that is our most preferential position, although we would accept an objective standard, yes.
But that makes decisions for physicians difficult. It puts the physician in a position of potentially being criminally charged. True that nobody has been charged yet, but by gosh, can you imagine going to work every day and being scared that you might run into a position that you could be criminally charged? Criminal charges are, as Chairman Farmer has said, much more different and dangerous. There's a situation in which the physician's malpractice insurance carrier will not cover the expenses of it or defense of it. And the cost of defense in this day and age, which physician would want to take a chance? And the pressure, on one hand, you have a mother, a baby's life to be preserved. That is our Hippocratic oath. That's the reason we went to medical school, and that's the reason we are there. On the other hand, you have personal fears for yourself, for your family, and the stigma and the consequences of a criminal charge. That is equivalent to saying to a person, I'm going to throw you in the river. If you get in trouble, I'll throw you a line. That is your affirmative defense. It just is scary. So we cannot leave this trigger law be as it is. We have to protect our doctors. We have to give them comfort of practice so that they feel good about it. So they feel they're fulfilling their Hippocratic oath. They're doing God's work. They are saving, preserving lives. That's what physicians do. I think that's a very major thing that you did not seem to worry about because that was your preferential position. I'm concerned about that, my friend, really. We have a lot of respect for you, as I said, but I'm really concerned that you did not seem to care about it. And the other things that need to be done, again, non-viable pregnancy or ectopic pregnancy, those things need to be corrected. In the face of that, it is difficult for you to say that that is your preferential thing, and you would rather let the law stand. I'm really surprised that you would be, never mind, I don't want to say that. But I think those things are really important.
May I respond?
Thank you, Madam Chair.
Thank you, Representative Kumar, and the respect certainly goes both ways, as we discussed this morning. Just because I have a preferential option doesn't mean that I'm not open to other scenarios, as I think I've made it abundantly clear to this committee, both in your offices and in front of you today. I want the law to stay as it is, but I am open to clarifying definitions, and I am open to an objective standard, so you can't say that I'm not willing to move on this with the will of the committee. I just think that there's a better way for it to be done. so that the intent and the nature of the law as it was written maintains, and so that everybody feels more comfortable with it. And I think that that is still possible, just not in the language that's been presented today.
Chairman Kumar.
Thank you for making a concession, but again, I would have liked to see you as a friend be as concerned about a physician who is under that degree of emotional stress and pressure trying to save the life of a baby and worried about being prosecuted. I would have liked you to be gushing in sympathy for that. That's what I would have liked to see from you. Also, you mentioned that this bill negates the heartbeat bill. Well, it goes better than the heartbeat bill. The heartbeat bill made abortion illegal once the heartbeat is heard, usually around 8 weeks or so. This bill, basically, the current law that we have, it absolutely says no abortion. Right? So we are going better than the heartbeat bill. Don't make anybody think that we are doing away with the heartbeat bill. We are doing better. Thank you.
May I respond, Chair Lady? We are doing better, and I praise God for that, and I thank you all for that, because you all are the ones that voted for it in 2019. But if this law, the Human Life Protection Act, were to be repealed by a future General Assembly or enjoined or overturned by a judge, and this bill that is presented today passed, there would not be a heartbeat law to fall back onto if the Human Life Protection Act ceased being effective. That is my concern. I do agree that it is doing one better than the heartbeat law, and I'm grateful for that. But if there is no heartbeat law to fall back onto, it doesn't matter.
Okay. Wanted to ask the committee, does anyone have any more questions for Chairman Kumar?
Well, thank you. I think I'm thankful to you for the acknowledgement that this is better than the heartbeat law. As far as in the courts and otherwise what's going to happen, we do not know. But what I would say to you is that you can count on this legislature, the state of Tennessee, and us to protect life. You can count on it no matter what happens in the courts. Thank you, Madam Chair.
Thank you.
May I have just one more response?
Well, first I need to check and make sure with the rest of the committee members if you've got any questions for any of our other ones that presented testimony. Okay.
Thank you.
Well, we'll hear from Representative Hemmer here for the Dr. Fortner. Director Sy.
Thank you, Madam Chairman. Thank you, Dr. Fortner, for your testimony today. I had a question based on your experience. The gestational age definition here in the bill says gestational age or gestation means the age of unborn child is calculated from the first day of the last menstrual period of a pregnant woman. From OBs I've spoken to, they're a little bit worried about this definition and may think that an ultrasound or there may be some better ways to term the gestational age. What do you think based on your experience?
I see. Just to confirm, so you're asking for clarity on the best way to successfully date a pregnancy. Is that correct?
Yes.
Okay, great. So yes. So dating from the last menstrual period is the traditional, and so all of this is defined by ACOG, our governing body, as well as AIUM, so there are multiple professional societies, and so you're correct. So it's usually last menstrual consistent with ultrasound gestational age. Certainly there are occasions where a woman does not realize or does not have a regular menstrual cycle, and so you're right.
Great, thank you.
Thank you.
I had another question just based on your experience. One of the sections in Section 2F here states that except in a medical emergency that prevents compliance with subsection B, the physician performing or inducing the abortion shall provide a pregnant woman with a duplicate copy of the consent form signed by the pregnant woman. How often in doing your profession are you giving a piece of paper to a woman after a surgery or serious medical issue? I'm just going after thinking, most things are even in the prior section it lists or areas. It listed about actually it is a prior section about the woman's medical records. Most things are documented electronically. We have prescriptions, everything. It just seems like it's, almost badgering or pestering to provide, and also putting undue administrative burden on a physician to providing a copy.
It's very kind of you, sir. So I think there are numerous instances where we give patients additional information or additional paperwork. There are other facets of the bill that I am so thankful to see. So if I am also required to give an additional piece of paper, that would not encumber me greatly. When we do research, we often give patients a copy of their informed consent in the pursuant of medical research. If I do a CVS or a procedure, I send them home with post-procedure instructions. So there are many other aspects of the bill that have my attention and appreciation. And so if it comes with giving an extra piece of paper, I would imagine that Tennessee providers would not have a problem with that.
Thank you.
Thank you, Representative. Is anybody else? Any members got any more questions? Chairman Farmer?
Thank you, Madam Chair, and appreciate you being here today.
Thank you, sir.
Have you had the opportunity to read this piece of legislation?
Yes, I have.
How long have you been practicing?
I finished medical school in 2001, so I've been doing OBGYN since 2001.
Okay. Do you have any questions, and are you clear to what this mandate would be as a policy standpoint? Is it clear that we want you to look to save the life of a baby if at all possible, and that is the life of his mother as well?
Yes, sir. Part of my reason for saying where I grew up and where I'm raised is that we are Tennesseans. So I really agree with Representative Kumar that we live in the same state. Our intention is to maintain pregnancies at all costs. And so, yes, sir, I do find that the further description, the delineation, and the specifications without being too specific, even practicing and seeing ultrasound since 2001, I still see new anomalies every day. So we can't list every possible scenario, but it is the general intent, and it provides clarity in this bill that we do not see in the current law. Okay. The current law has us afraid. Okay. Thank you for saying so.
And just, I know there have been some folks that testified today that's afraid that there's going to be maybe some doctors are out there that's going to try to usurp our intent and perform elective abortions, even though this bill makes those illegal, doesn't speak to it. But do you see a way, and I think this is this is a tightly worded piece of legislation, do you see a way that doctors could usurp our intent?
No, sir, I do not.
Okay. And then could you speak to those, you just said something I was going to ask earlier about those fatal fetal anomalies? And
yes, sir.
You made the comment there's too many to mention.
Right, there are different, so there are conditions that are genetic. There's something called limb-body wall where I feel like it's not even the easiest things to hear, let alone explain to a patient or family. But right, so there are syndromes and different sequences, but if we agree that the heart is outside the chest wall, there is no way that that's survivable. So I think that even though there are numerous ones that are too numerous to count to put in a law, but it is all generally understood that I'm not going to game the system, that if there is a heart outside the chest or if there is no calvarium and there's just a brain in the amnion, that it gets degraded throughout pregnancy. And so we do not survive when we do not have an intact brain.
Okay. And I know the bill's drawn a bit of criticism because we had not defined those fatal fetal anomalies, and I'm glad you spoke to that because not everything's black and white in my opinion, right? Unfortunately, I practice law, you practice medicine, your job is much more important than what I do, and thank you for what you do.
This is our intersection.
And I think if we could have and had the ability to name everything and define everything, we certainly would have. Mm-hmm. And I think that the intent behind this legislation, the policy behind this legislation is to, make certain as much as possible and put into it what we can put into it, and just and hopefully our doctors will follow suit. Otherwise, they could potentially end up in jail. So, okay, thank you so much.
Thank you, Representative Farmer. Can I add one detail? So, is that all right?
Yes.
Thank you. Sorry. When we were talking about letting things work out in the natural course, so one specific example to highlight some of that gray area is pre-viable PPROM, meaning when the water breaks early before a survivable gestational age. So if there's no water around a growing fetus, then the lungs don't develop. So that is one of those gray areas where with counseling and time, assuming everything is stable, we would have time to sort of present the options of continuing pregnancy and hoping for the best versus ending the pregnancy and inducing her. So we had a patient recently, since the law changed, who elected, obviously the only choice was for her to go home. And so she went home. She came back and she was septic and hemorrhaging. And so I think we cannot undervalue the importance of now she's in septic shock. She was at risk to lose her uterus. And so it is not always so clear that things don't always just work themselves out. That, as you said, modern medicine and technology allows us to understand and work through a problem together.
Thank you. You have any more?
And I was going to, if I could,
Okay.
I was going to ask about that because it was brought up, well, we need to wait. It seems like, some testimony alluded to the fact that we need to wait till those emergency situations before we make that decision. How important is it to be able to have an opportunity and use your skills and expertise and machines and technology in a situation like that? If you've been able to, does it make a difference?
Yes, sir. It is a significant, in my mind, misuse of resources. If she did not need to have 6 units of blood, that could have gone to the trauma victim or the gunshot wound. Blood is a limited resource. And so just because she can wait and come back in and she still lives to talk about it today, one, that won't always happen. And two, it also is a significant misuse of an ICU bed. It is a preventable occurrence.
Okay. Thank you. Thank you, Madam Chair.
Thank you, Chairman Farmer. Does anyone else on the committee have any questions for any of our ones who have testified? Okay, we will go back into session, and I'm going to recognize Chairman Haynes. We are going to see if your amendment makes the bill. Is that correct?
Yes, it does. It rewrites the bill.
Okay, so looking for a motion and a second that we vote on accepting the amendment to be added. And speak, oh. Okay. Speaker, Chairman Haynes, yes.
In closing, I would just like to say that these moms want their babies. They're not looking for an abortion. Something goes terribly wrong in their pregnancy. And I feel physicians shouldn't have to hesitate when they know what needs to be done to take care of these mothers. Oftentimes, they have other children at home. I think this is a truly pro-life bill, and I humbly ask for your support. Thank you.
Thank you, Chairman Haynes. So we're back in session. And do we have so we've got one more member that would like to speak, and that would be Speaker Sexton.
Thank you, Madam Chair. Representative Helton-Haynes, thank you for this bill. Let me just say, I'm down here not because I think this vote's going to be close. I'm down here because something happened that I've never experienced in my time down here, which was somebody on a committee testifying tried to intimidate our members by telling them they were going to score them a vote. You can have those conversations in your room. You can have those conversations in email. But to do it in the committee, to try to intimidate this committee to go a certain direction is uncalled for. So I'm here to support, to support this bill, to show you all the support on this committee, whoever votes for it, that I stand with you and not having the intimidation come before this committee. Thank you.
We got to have a vote on the amendment. So all in favor of adding the amendment to the bill, say aye. All opposed? The ayes have it. So now we have the amendment. And Okay, okay. So now we have the amendment added on to the bill. So now we have some questions from our members to Chairman Haynes. So I'll recognize Chairman Clemens first.
Thank you, Madam Chair, and sponsor, thank you for this legislation. I appreciate your passion around this subject. You know, this law, which is the most restrictive, dangerous law in the country on this topic, has been around for several months, and it's several months too long. So I appreciate your willingness to lead the effort on this and carry the legislation to try to correct some of it. It's completely unjust for Tennessee women to be treated as less than equal under the law. It is not right that women in Tennessee have had to travel across state lines to receive emergency life-saving care. It is unfair to put doctors in a position, and they should have never been put in a position, where they were considered guilty until proven innocent. Now, I wish we had had this conversation a little bit more in depth before we passed the law that brings us here today, but I do appreciate you for at least trying to solve some of these problems with this law. Now, most people know where I stand on this issue. I've been pretty vocal about it for the last 9 years in multiple debates on legislation. But in a legislative body, we don't always get what we want. And it's especially true as a Democrat around here. But it is important to find common ground and work across the aisle to make progress for Tennessee families, women, and doctors, regardless of whether I personally or subjectively consider it too little progress. For this reason, I'm going to support this legislation proudly as a minimum step in the right direction for women, families, and doctors. So thank you.
Thank you, Representative Clemens.
Thank you, Chairman Clemens. Has anyone else got any? Chairman Terry?
Thank you, Chair Lady, and have the utmost respect for you and on the fight, and we've had discussions on this. I still have issues with how the definition is, the prevent in there, and again, I'm not sure that I can get there, but I do know that I do support in emergency situations, and I think that's a step in the right direction. Good faith medical judgment in that. I think our doctors have had issues when it's life and death. They have to make those steps. I'm hoping that we can get me comfortable with this legislation, but for that reason, I'm probably I will be voting no on this. But thank you.
Thank you, Chairman Terry. Anybody else? Okay, Chairman Rutter.
I just have to say that I'm very proud of my friend and colleague, Esther Helton. She's always Esther Helton to me. But I'm also proud of our medical community for testifying here today. And I know as a mother, I think, as my colleague said, there are two lives involved here. There's the mother and the baby. And I feel confident that our doctors are going to try to save both lives. But in a medical emergency, maybe with the passage of this legislation, they will have some leadway without criminal charges being brought against them to save that mother's life if it's absolutely no other option to save the baby. And I'm proud of this piece of legislation and the work that's gone into it, because I have been privy to a lot of the conversations because we're good friends. And I understand how hard this has been for everybody on this panel, on this committee, to wrap our brains around this piece of legislation. But I think it's a good piece of legislation that needs to be passed so that we can save the life of the mother and hopefully always the life of the child. So thank you.
Thank you.
Thank you, Chairman Rutter. Does anyone else have any comments? Okay. We will be voting for House Bill 0880. 0883 as it has been amended. So all those in favor say aye.
Aye.
All those who no? The ayes have it. House Bill 0883 will be moving on to full health.
Thank you, Madam Chair and committee.
And got a motion to adjourn? Thank you.